Good morning, and welcome back to Good Samaritan Facebook Live. My name is Dr. Scott Stine. I'm a family physician here in Vincennes, Indiana, and Chief Medical Officer of Good Samaritan Physician Network. Joined today by Adam Thacker, who's our Chief Operating Officer. As usual, we will be bringing you Monday morning updates on status of COVID-19 in our community, a bit about our current statistics, also where we stand as far as what we're doing with testing, go over our universal precautions and masking guidelines, of course, and kind of talk a little bit about where we go from here. So just giving an update kind of on basic numbers, around 79 active cases in the community, and this is the thing that we really try to focus more on now than what the totals were, around 340 total since we started all of this. But the other big thing that we go back to is the positivity rate. And Adam, you want to talk a little bit about the positivity rate and kind of where we are, because really that's what's giving us sort of the finger on the pulse of what's happening locally and then compared to the rest of the state, really.
So that 7-day trending positivity rate's really what we're honing in on. Tells us are we moving up in transmission? Are we moving down from a community transmission standpoint? 13.6% if you go and look at the Indiana State Department of Health website. That's, while we've seen a few percentage points over the last couple of weeks change, that's been pretty consistent, 12 to 15 range, and following that. That's almost double what the state is seeing. So we're one of the areas that have seen increased transmission over the last month. Certainly the month of August, a pretty significant jump in cases, over 100% increase as we went to that 340 total cases. But again, focusing on active cases and patients that are in the hospital and really requiring additional medical care. The vast majority of our patients are recovering at home, under quarantine, being followed by Dr. Stewart and our health department folks and managing them in that regard. So we still remain very positive on we're not seeing a number of patients that are requiring significant intervention from a healthcare standpoint, which is good and what we want to see, because transmission is to be expected.
One of the things that sort of protected us before was geographically our location. We were away from population centers, and when we initially saw things break out in March and April, we saw very few cases, almost no cases. We have since seen an increased trend as things have opened back up, kind of as we would have expected. And so if we look at the holidays that have passed over the summer and events that have occurred, we saw a fairly steady rise after things opened up. And so that's very important why we continue to go back to the universal precautions and universal masking for right now. And I think as of right now, the plan is that that's going to be extended at least another month from the governor, as far as we know.
Yeah, the latest update extended that through September. And as Dr. Stine mentioned, you can certainly look at holidays, Memorial Day, 4th of July, and now coming up, Labor Day. So it's worth mentioning universal precautions with our masking, outdoor venues, keeping still social distancing space, using hand hygiene to a high degree, and just being cognizant of if anything feels off, staying at home. But as we move into Labor Day, it's a time for events and gatherings. A number of large events that are community focused are not occurring, have either been pushed back or canceled until a later date. So now even looking at more private events at homes and those types of activities, it's not something that we're saying it's a back to shelter in place and you can't have those, but everybody needs to have a thought process around what that's going to look like and doing that in the safest way possible and really controlling the size of those gatherings, and certainly indoor versus outdoor. Take advantage of the nice weather and utilize outdoor spaces as much as possible.
Absolutely. I've had a number of people ask with regards to the positivity rate, why such a dramatic shift? And while geographically we were somewhat protected initially, one of the densest population areas of cases is just out to our east, 2 counties to our east. And so part of the challenge is that we have that right next door, which makes it a little bit more easy for that to be transmitted back to our community locally. The other thing that makes a big difference with regards to the positivity rate is how many tests are being done. And so if we look as far as the entire state is concerned, many more tests are being administered in somewhat more of a loose indication, I would say, as compared to what we're doing here. We're still fairly tight in terms of who we choose to test, and we test people that we think really are going to be positive, and therefore the positivity rate is going to be higher. Throughout the state, with the colleges going back into session, schools going back into session, and athletic organizations requiring testing, there are lots and lots of tests that are being done statewide that are going to be done on people that have a very low likelihood of having a positive test. And therefore, those numbers tend to be diluted a little bit more, and I think ours tend to be more concentrated.
Yeah, it's a sheer numbers game when you talk about positivity rate. As Dr. Stine mentioned, if you are increasing your testing all the way up to asymptomatic testing, what we call surveillance testing, that you're just testing a population for sake of knowing where do you stand on that day, that's going to drive a positivity rate down because you're not suspecting of something. In our case, where there's a provider assessment at convenient care or at our primary care offices, the test is more tied to there is a symptom, which can be a wide range of symptoms. Yes. But there is a symptom that has our physician or nurse practitioner or physician assistant thinking this possibly could be COVID, and let's check to be sure. So that's automatically going to push up our positivity rate as we're testing suspected patients rather than just a global asymptomatic testing.
And again, many people will ask, well, why aren't we testing asymptomatic people? And the answer simply is that we want to do tests that we would take action on. And that action, of course, is not necessarily that we're going to treat those patients any different, right, but it's how we isolate those patients, when those patients can return back to school, when those patients are safe to return back to work, and then, of course, what their contacts are. One big thing that came out last week that we're still kind of waiting to see the rest of the backstory on is the CDC said, hey, there's really not any need to go out and get tested just because you've had a primary contact. And we basically have had that approach if we go back to the beginning of this, that because the testing really doesn't change much of anything, it's really more about if you have a close contact, if you have been around somebody for 15 minutes, a period of time, in close contact with them or have a primary contact in your household, we assume that you've had an exposure. And therefore, testing doesn't help nearly as much as saying, hey, best thing for you to do is to wait and quarantine yourself, and when time runs out, then it's safe to return back to normal activities.
And high-risk individuals as well, even if they're asymptomatic. If you have heart disease, lung disease, something that would potentially be tied to a more difficult time recovering from the coronavirus, then we may do asymptomatic testing in that regard as well. But one thing that aligns with is from the get-go, we've tried to follow CDC WHO guidelines from an international standpoint, and really follow that with the best information that we have today. And sometimes that moves back and forth. It's a very fluid situation, but as that recommendation came out, we already were adhering to that, and certainly are anxious to see what that next level of information means for that asymptomatic population.
And Adam also mentioned the issue of schools, and we've been working very closely with our local superintendents as they develop their own guidelines and how they're going to deal with positive cases in their schools. We are going to be meeting with them every couple weeks, I believe, in an ongoing basis, because just as Adam said, this is such a fluid process. We want to base our decisions and recommendations based on the most current data, and so we'll be doing that again, I think, later this week as well, correct?
Yeah, and to speak a little bit to the governor's update, or Dr. Box on the governor's update related to schools, I know many follow that Wednesday update or pick it up afterwards as to what was communicated on there. We've seen that dashboard really evolve into a very useful tool, and now it stratifies further to where there's long-term care facility information, and coming soon school-specific information, as those are populations that everybody wants to know about, and they're trying to be transparent with the data. With the school, they have developed, based off a positivity rate and increasing trends and certain factors, a scoring system that essentially becomes a color-coded system from blue to yellow to orange to red, blue being you're seeing very low community transmission, to red being very high transmission. And there's some recommendations tied to that, from in-school extracurricular activities, all as a go, up into limiting things, which red is more of a virtual. I do want to qualify that those are recommendations from the state, and schools and public health officials, hospitals that's why we're coming together to have those conversations about what that looks like for each community. Because there are counties that you can go look up right now and are red, and to my knowledge, some of them aren't just automatically going to virtual because they're looking at the risk for that population and what that looks like for on-site learning versus remote learning. But it's a very active discussion that's happening regularly between Good Samaritan officials, Dr. Stewart, and health department officials, and the school officials working collaboratively.
And I think it's important. People ask me on a daily basis, is it safe to send our kids to school? And the best endorsement I can give for that is my kids are in school right now. They walked out of the car with their mask on. They've got their own water source, and they're playing sports. And so if it was not safe, I would not be sending them.
Right.
When we meet with our school authorities and school nurses and superintendents, one of the things that we try to reassure everybody about is part of universal masking is that we know there are cases out in the community. We know that there are people walking around that are asymptomatic. We don't know exactly who has it or who might be potentially spreading virus, but that's the reason for the universal masking, is we are protecting each other by wearing those masks. And so not to bash on us adults, but I would say that the children are much better at this than what we are. They follow rules and they do what they're told, and they're used to those type guidelines in schools. And so the schools are doing a very good job with that. Our children are doing a very good job with that, and we need to reflect that in what we do as well.
Yeah, I catch myself getting reminded by my kids as of this weekend, do you have your mask? So I mean that has become a habit for them that is just as normal as grabbing their backpack or their lunch to take to school, whatever that may be.
Testing is always a subject. We continue to do testing through our testing facility out at Convenient Care. We also have a testing facility that is up and running that's at the Medical Center of Vincennes, which is over on 1st Street. The idea there is we're trying to make the quickest accessible tests through a variety of modalities, meaning that if you need to be evaluated and you don't have a primary care physician, you can be seen and evaluated at Convenient Care. If you have a primary care doctor and they work through any of our network, the MCV location test can be ordered by your primary care doctor, and that can be done in a quick fashion. Those test turnaround times are better now than what they were in the past.
Yeah, we're seeing a 2 to 3 day turnaround time, and as we've talked about so many times, that everybody wants that instant information back. But if you're symptomatic, assessed by a provider, there's going to be a self-isolate component anyways. So we're turning those tests around in that 2 to 3 day window, which is by and large, when you look at national statistics, outperforming just the global numbers of when tests are being turned around, which is more in the 3 to 5 range.
And it's important too, as Adam said, if you're symptomatic or if you are sick, meaning that you are having difficulty breathing, you are coughing, you are wheezing, you are having a difficult time keeping fluids down, and so forth, we want you to be evaluated right away. And that's something that is available every day through our primary care offices, also through Convenient Care. And so that patient, it's fairly clear we want them to be seen and evaluated clinically. We have a variety of other methods that we can see and evaluate those patients too, either virtually or through telephone triage. And so although it may be a little bit difficult when you initially have symptoms in terms of I have headache, I have some fever, I have some rhinorrhea or runny nose, what to do about it, we have a variety of modalities to help get patients plugged into the system, get that seen.
Our triage line, 812-885-3331. You'll get connected to a nurse who can help to navigate that virtual visit, on-site visit, go to Convenient Care, maybe even go to the ER if they identify that there's any type of breathing distress or anything that requires a higher level of urgency of being seen. We have, if you utilize our MyChart patient portal functionality, there is a web-based interactive symptom checker for COVID that will also then direct you to, okay, what are the next steps? And then if you're established with your primary care provider's office, you can contact them and they can help with navigating that system. But certainly if you are having symptoms, someone in the house is having symptoms that align with this may be COVID, that next step is seek care and we'll give you direction. And I think it's important to note that sometimes that direction is quarantine, stay at home. If symptoms worsen, then contact us and we'll take the next step. But we have seen a very large population of COVID positive individuals or even direct exposure individuals that have recovered at home, don't need any other intervention, but start with that phone call and we'll guide you through that.
Yep. And a lot of those processes really are relatively new, but have been streamlined a lot over the course of the past few weeks. One of those things that we have optimized recently is the process of people do need to be admitted to the hospital, how they get into the hospital, and who they're evaluated by. We're very fortunate that our pulmonary critical care doctors are working with our hospitalist service, and for patients who we know are going to need to be hospitalized, they are getting into the hospital in a quicker fashion, being evaluated faster, and then being stratified to what level of care that they need. And another thing that you may hear us talk about, and we've really gone over since the beginning of this, is ventilator availability, bed availability, so forth. And if we look on that Indiana State Department of Health website to see the dashboard, the good news is we have plenty of resources that are available. So although there was a lot of concern and worry early in this process, and we really wanted to push off the timeline as to how many sick patients we saw over what period of time, all of that has been ramped up, and not just locally, but regionally, and then also statewide and nationwide. We have lots of resources that are available now. And so when patients do come in and are sicker, we not only have the bed space available and the personnel available and ventilators available to take care of those patients.
Yeah, our capacity continues to be strong. We're able to respond. I will add that one discussion that we're having this week is around visitation, and it's an ongoing discussion. So if you have a loved one, friend, family that you're part of their care team in the hospital, certainly look up the visitation policy online, be knowledgeable about that, also respect what that visitation policy is. We are trying our best to balance that dynamic of family and friends able to be part of the care team and part of the recovery process, which is certainly a critical juncture in healthcare, with the safety of our healthcare team, with the safety of other visitors. And it's, as you see community transmission increase, it is not out of the question that visitation may need to be restricted further. The best option moving forward to be able to continue to allow visitation is that everybody is following the guidelines to a T. If our care team is having to address issues outside of caring for patients due to visitation, then we will simply have to reduce visitation, and that's something that we don't want to take that step, but the patients and our healthcare team have to come first for their care.
And one thing that we always encourage, and this is outside of COVID and everything else, is that every person who's in the hospital should have some advocate for them that is a primary contact. Because when nurses need to communicate with patients and families, when providers need to communicate with patients and families, we really need that point person. We need that person to talk to. And that will be the person that we also communicate the changes in the guidelines as far as visitation goes. Because this is something, again, that's changing nearly on a daily basis, depending upon how many patients we have in the hospital and what the community transmission issues are. So we really encourage people to have one primary contact, and that's the person that a lot of that communication is going to flow through. Any other hot topics you'd like to discuss today, or would you like to go to the phones?
I think we'll see what kind of questions we have.
My question is, what's the rate of false positives?
Sure. So, and that is a little challenging because it depends greatly upon the tests. You will hear all different types of tests and all different types of quotations with regards to what the false positive rate is. We have spoken primarily about the false negative rate because we worry more about that. False negative rate can be as low as 1% to 2% or as high as 30%. And what we have found with that is it has probably more to do with the collection method than anything else, than what it does with regards to the test itself and how good the test is. The false positive rate really speaks probably more to the antibody testing than anything else when we speak about that. And that really is because we all have been exposed to some variety of coronavirus over the course of our lives. And so those numbers really don't hold up very well because what we're specifically talking about is exposure to infection with and antibodies to COVID-19. And so it's very difficult to isolate that because of all the different types of antibody tests that we're speaking of and all of the different types of coronavirus that we've been exposed to over the years.
Another piece of that is that provider assessment that we talked about and testing appropriately because there is suspicion of potential coronavirus also keeps our false negative rate lower. If we were testing asymptomatic without kind of clear indication that there's a risk here, we would likely see more of those because if you come in contact with coronavirus early on and we test for it, you may not have produced what's called the viral load in time for that to be detected. So that's something that we're looking at very, very closely and trying to control that. From just a pure lab test standpoint, that specificity and sensitivity, the testing that we're using is one of the highest degree tests that you can use, has FDA approval. There are a lot of tests coming out, and we're evaluating what the new testing methods look like, whether that is a saliva test versus a NARES test versus the long swab, which is in the nasopharynx area. And we're sticking to that because that's the gold standard today.
And one of the things that Adam alluded to there, which is very important, if we play that out in a real-world scenario, is that one of us has the virus and the other one is exposed to that person, and then they run off immediately and go get tested.
Right.
The likelihood of that test being positive on the person who's been exposed is almost nothing, unless the two of us got exposed at roughly the same time, had roughly the same incubation period, and then one developed symptoms before the other one. The fact of the matter is that the person who is exposed also needs that incubation period. And that brings up a bit of a heated point as to why we isolate and quarantine positive patients for a shorter period of time than patients that haven't turned positive yet or just had exposure. You want to talk a little bit about that?
Sure. And that's that you hear the 10 days versus 14 days. So if you test positive, we already know kind of that point in time where you have the virus and then what that recovery of symptoms to be considered recover is. The 14-day window is because if you do come in direct exposure, then there is a time period, what's called the incubation period, that starts at day 0 and can go all the way up to day 14, where it seems kind of odd because it is an extended period of time. And we have folks that may be quarantined at home and are released from that and considered recovered sooner than those that they may have exposed. But it's all based off of that incubation time and the testing that says you have the virus versus this is a period of time where you may develop the virus, you also may not. And I'll throw in that one more plug of if you were both masked, then there wasn't likely a direct exposure and very, very low risk in that. So that masking piece, for those that don't want to have to miss work, I mean, that keeps you in that low-risk category and keeps you from missing work.
Tiffany?
Now with more patients being hospitalized in ICU, what are the treatments? Are we using plasma or other types of treatment on these patients now?
Yeah, so there are a number of treatment options. Our intensivist team, our hospitalist team, the physicians and the care team taking care of the patient are assessing all of those options. You've probably heard of convalescence plasma. We are enrolled with Mayo as a large national provider in a study related to convalescence plasma. So we have the ability and have utilized that at Good Samaritan. Probably the more common treatment that we're seeing here locally based off of just the acuity of patients is Remdesevir. And that is an antiviral drug that has been tested and widely publicized in the news as far as a treatment, and we've seen some success with that. It certainly is not at a point that it treats everybody with coronavirus and they respond and get better, but it is a treatment modality. And you hear about steroids and fluids and intubating of patients versus not, and oxygen. I guess the simplest answer that I can give is all FDA approved and off-label study approved coronavirus treatments are available and at the discretion of the physicians caring for our patients that they can be utilized. There are no treatment modalities that we would say we cannot do here.
And the other thing that people frequently ask about is the intubation process and a process that's called proning, which is basically flipping the patient over, and it helps with ventilation. But the main thing that happens with a lot of patients who have this is they have such an inflammatory response all over their bodies that we treat them very much like other ICU patients in that manner, meaning that we have to support their blood pressure and we have to support their breathing and we have to support their other organ function and nutrition. And so a lot of it is supportive care. And as Adam mentioned, the treatments that we have available are being initiated as soon as we we see that those patients are evolving into that more critical standpoint. People always, of course, ask about hydroxychloroquine, and without question, what we have seen study-wise is hydroxychloroquine used in the horribly ill patients in the ICU has not proven to be helpful at all, and potentially more risky. And so when you interact with providers and the folks who are experts with this, they will remind you that we really just don't have any positive evidence with regards to that. Remdesivir definitely has shown to be helpful. Some of the ventilatory strategies that we use have been shown to be helpful, and then again, steroids and anti-inflammatories that basically help reduce that inflammatory process in the body and the lungs have been shown to be helpful as well.
Now with like mask mandates, someone asked about the rules for like fast food restaurants or meat markets. So should those employees be wearing masks, especially like at the drive-through window?
Yes.
Yes.
And not only should they be wearing masks, but they should be wearing masks correctly. And I think that's probably, we have certainly seen over the course of the past several weeks a higher percentage of our population wearing masks, which is fantastic, and that's what we are hopeful for. One of the challenges, of course, is wearing those masks appropriately. And having your nose exposed or your mouth exposed or your mask on the top of your head or down on your shoulder or your sleeve is not very helpful. Now, the thing to keep in mind is when you are not in an environment where you are around other people or would have close contact, you do not need to wear your mask. So as you are walking into a retail type store, it's okay to not have a mask on, but as you are approaching that facility, you need to mask up. And we went into a number of those facilities, and just like Adam was saying, my kids had their masks on before I did. And so it's important to realize that that is the new standard right now. And until we can see a reduction in that community transmission, that's going to continue to be the case. So what we anticipate seeing is at some point in time when we see those numbers drop, the mask mandate will likely be removed. However, we will probably still encourage some of our higher risk patients to continue to use mask precautions, and family members and people that are around them to use those precautions. So we all wish that we had a date that's the red letter date. We know masking is going to be over. I would plan on it until the spring, and if it goes away in the next few months, then it'll be fantastic.
And I would add that we get questions about our mask unhealthy, and we've addressed this, but they're uncomfortable.
Unpleasant.
Not unpleasant, not unhealthy. And would add further that we've seen some folks, patients come to the hospital that have had a mask exemption. And while that may be the case due to a breathing disorder or trouble breathing or something along those lines, a face shield will be required in coming into Good Samaritan. So that's an alternative to a mask, is the face shield that still covers the respiratory droplets, because that's what we're doing and protecting everyone. So if you cannot wear a mask and have discussed that with a physician and decided that it's in the best for you not to wear a mask, a face shield is going to be required as an alternate, at least in entering a healthcare facility. And I would strongly suggest that per that mask mandate, that's the alternative that you would use entering any public facility.
Absolutely.
So for an asymptomatic person that needs to have a COVID test for like a trip, that they need to have a negative test, can they come here asymptomatic, or where should they go for that test?
Sure. So the state-sponsored free testing sites are set up in Gibson County and Vigo County. There's a website through the ISDH that you can go and look at testing. So that's a resource that can be utilized for asymptomatic testing. For some international travel is requiring that, and can go there. You can also contact your provider and have that discussion of, can they order a test for you, and you can come through Good Samaritan and be tested, so long as you have a provider order. So that's really the difference, is you have to have a provider at Good Samaritan that has said, yes, let's do that test, and they will order it. At the state-sponsored testing sites, it's what's called a standing order, so you're able to just request that and be tested. And it really comes down to the volume of our community that's needing to be taken care of. Our focus is, are you symptomatic? Is there a clinical reason that we need to know? Although I know that some areas are requesting or requiring that you have that test.
And we do asymptomatic testing for preoperative patients that have to go for surgeries at certain locations, things like that. But again, as Adam said, our priority has always been to focus on the patients that we are most concerned about, and as the throughput allows, asymptomatic testing at our facilities as well.
Okay, someone mentioned testing that was being done up in Indianapolis, that they actually gave some supplies to them to test themselves. Is that an acceptable way to test?
As Adam kind of alluded to, there has been a whole host and flood of tests that have hit the market. The problem is the FDA has waived a lot of the requirements for how those things are certified. And although some of those may be perfectly legitimate and reasonable tests to perform, we really are trying to stick with tests that we know the statistics on.
Right.
We know who is running the tests. We know how the tests are being collected. Because even in the best environment, the statistics are not fantastic. It's not as good as a strep test. It's not as good as a mono test. And so we want to control as much of the quality of that as we can. And so while there are all kinds of saliva tests and home tests and things like that, I can tell you personally through the history of medicine, when we look at other types of tests like that have been performed at home, they do not turn out well. It is very poor statistics, and a lot of it has to do simply with collection technique and the appropriate for when the test is administered. And so for now, I still feel very strongly that we need to stick with tests that we know work and that have FDA approval. And although people will say, well, this is an FDA waived test, that simply doesn't mean the same thing.
Yeah. I would say our recommendation is that COVID testing is performed by a medical professional.
So someone asked how valid the test results are if the test it takes like 3 days to get processed through the lab.
So if the question of validity is how valuable is it to then reflect upon whether that test was positive or negative, it's still quite valid because a lot of times if a patient comes in and is symptomatic, the return to whatever activity is at least 72 hours of fever-free or symptom-free. And so right now, because those testing results are coming back within 2 to 3 days, it is valid and it is helpful. When we were running shortly after 4th of July, where those testing results were 5 days, 7 days, and plus, it wasn't terribly helpful because it wasn't going to change anything about when that person was going to return back to activity or school or work. And so we are doing the best with the quality of the tests that we have, but now that we see there's a high enough throughput of those tests that we get the results back, I think it's not only valid, but it's still helpful.
Right.
Okay, what are the quarantine guidelines when someone in a household is being tested? So for that whole family, how long should they quarantine? Should they quarantine until test results come back? What's that guideline?
So it centers around that direct exposure, and so if you're living in a household with somebody who has been tested or has the test results back as positive, and there's that direct exposure, then it is expected that the household is quarantining as well. So that really starts at point of test pending. So when you have a test, it goes into what's called the pending status until the results come back. So when we perform a test, we're performing a test because we expect that we are testing somebody who is positive. So any pending test that we have is assumed positive until proven negative. So at that point of test and pending, anyone in the immediate household that would be a direct exposure does need to quarantine at home. It certainly in a family setting, having a discussion of if one of your family members tests positive, how you will still maintain some distance in the home as much as possible is important, but it does go based off of direct exposure, and anyone in that home would need to quarantine as well.
So if there's a patient in the hospital that is positive and on the ICU, maybe even with the ventilator, can that patient ever have a visitor? Like, I guess, is there some point that they start to get better that they're allowed to have a visitor?
Yes. So the answer is yes, they can have visitors. We are limiting the amount of time and exposure of the family members primarily to protect them. And so as Adam was talking about earlier with community transmission, we understand we all want to be with our family members and we want that family member to be comforted, but one of our concerns, of course, is that those family members that come in that are exposed to somebody that we know is not only positive but critically ill with this illness, potentially even though they are accepting that risk of catching that illness and the consequences of catching that illness, them then going out into our community and potentially being a source of transmission really is the other big factor that we're dealing with here. So we're trying to balance that on a nearly daily and case-by-case basis as far as who gets to go in and see the patients and for what period of time and re-exposure and so forth. We do have a responsibility to make sure that patients understand the risk that they are accepting. Everybody, of course, is accepting that risk, but we want them to also understand that it's not just consequences for themselves, but for all the people that they are potentially exposed to. They're accepting that risk.
I think it's an extremely delicate situation, and as Tiffany asked the question, she asked about if somebody is getting better at that point, then can they have visitors? Actually, we would strongly encourage a virtual visit utilizing iPads if the patient is able to do that. It's more in the other side of exceptions where if your loved one is deteriorating and there is potentially an expected death, then we recognize that nobody wants any patient to ever die alone, and for family to miss that last period of time that they may have with a loved one. So it is case by case, and balancing that. I'll reiterate that our healthcare team and the safety of everyone in the facility is the thing that we have to prioritize. And so while sometimes those are difficult one-on-one conversations regarding an individual patient, we're balancing that in the best way that we can.
Okay, if someone is exposed, then test negative within their 14 days, are they okay to go back to work? Or do they still need to quarantine for the full 14 days because of incubation period?
The CDC guidelines and our health department quarantine align, and that quarantine is expected to remain for the 14 days. I guess I'll qualify that a little bit with, from an employer standpoint, you need to know what your employer expectations are as far as do you have telecommuting options to work from home? Do you have an isolated work environment where working away from anybody would allow for a work environment? But the recommendation due to exposure is that once there is that exposure, a test isn't a get out of jail free card. It is still, you have to be out that incubation period time. But from an employer standpoint, I won't speak for all employers because they may have avenues set up where some of that can be utilized.
Okay, that's all the questions today.
All right.
Thank you all very much for joining us. We'll be with you again, but next Monday will be Labor Day, so we may push that back a day or so and catch up with you then. So most importantly, everybody be safe over the weekend, not just with regards to COVID-19, but with regards to everything else that gets us in trouble. So wear your seatbelts, wear your helmets, be safe, and we'll be back with you in a week.
Thank you.